So good afternoon, everyone. Thanks again for joining us today. My name is Carolyn, and I'm the Alumni Relations and Annual Fund Officer at Bloomberg Nursing. Welcome, and thank you for joining us today for Laura's Lunch and Learn session featuring PhD candidate Laura Istanboulian, Creating Capacity to Communicate, Supporting Patient Communication in the Adult Critical Care Unit during the COVID-19 pandemic. Before we get started, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. I'm now going to cover a few housekeeping items for today's event. Since there are so many of us, we ask that you stay muted throughout the presentation, and we welcome you to enter your questions in the chat box. There will be a Q&A period at the end of the presentation, so we'll be sure to get to all of your questions. This session will also be recorded so that we can share it with those who are not able to join us today. So we'll send you an email after the session, which will include a link to the recording, as well as an opportunity for you to provide feedback on today's event. Now it is my pleasure to introduce today's speaker, Laura. Laura is a nurse practitioner that works with patients who are experiencing persistent and chronic critical illness. Laura graduated from Bloomberg Nursing, the nurse practitioner program in 2012, and returned to Bloomberg Nursing in 2018 to begin her PhD. Laura is in the final months of her doctoral research, and we will hear more about this today. Thank you for joining us, Laura. Over to you.
Thanks so much, Carolyn, for that introduction, and good afternoon, everybody. Forgive me if I'm turning my screens, as I'm really used to looking at people when I'm talking and you're all here, and my notes and slides are on this side. So I don't, just know that I'm looking at you all the time, okay? And thank you so much for inviting me to speak at today's Lunch and Learn, and for everybody to take time out of their schedules to come. As mentioned, the title of my talk today is Supporting Patient Communication in the Adult Critical Care during the COVID-19 pandemic. And a quick note of thanks to Dr. Craig Dale here, my PhD supervisor, and my committee members, Dr. Louise Rose and Dr. Yana, who were all instrumental in the design and completion of this work that I'm going to describe today. And when I say we, throughout the presentation, this is the A team that I'm talking about. I've also included some important donors at the bottom of this slide that I wish to acknowledge. So I'll just say I have no financial relationships or interests to disclose. I included the web addresses to credit some of the key images you'll see in these slides, and just to say they're mostly from Canadian news sources. And most importantly, patient privacy has been protected in the creation of this presentation. A couple more details about me, who's talking to you today. I'm a first-generation Canadian. I'm originally from Armenia. My family is there on the right side of the screen. My wife and I have two sons, Rafi and Gregory. And as mentioned before, I'm in my final year of the PhD program at the Lawrence S. Bloomberg Faculty of Nursing to defend in exactly 27 days. Not that I'm counting. And prior to this degree, I completed my Master of Nursing in the Adult NP stream at U of T, as well as an additional undergraduate degree at U of T. So I think I'm in grade 29 now. I counted this morning. So as mentioned, I also currently work here at Michael Garrett Hospital in the role of NP Clinical Director with the Prolonged Ventilation and Weaning Program. I previously worked in ICU, both here in Toronto and also in Vancouver. So I am in the hospital today, just as a disclaimer in case there are any overhead announcements or someone knocks on the door. And in the next 30 minutes or so, I'm going to talk about patient communication difficulty in the ICU and my doctoral research, which was aimed at addressing this complex clinical problem using a theoretical approach. So many patients in the ICU actually experience communication difficulty, and in part this is due to the placement of an advanced airway, such as a tracheostomy tube, which is on the left there, or an oral endotracheal tube. And these advanced airways connect a person's lungs to a ventilator, and their passage through the vocal cords actually directs inhaled and exhaled air in such a way that it leaves a person voiceless. And we know communication difficulty affects a large population. So globally, prior to the pandemic, there were approximately 13 to 20 million ICU patients. And in 2013 to 14, there were about 230,000 ICU admissions in Canada alone. And a third of these patients required mechanical ventilation via one of those advanced airways. And so this amounts to well over 75,000 Canadian ICU patients in that year alone at risk for communication difficulty. So I'll backtrack a little. My interest in communication, patient communication and patient communication difficulty originated from experiences as an ICU nurse. There was one experience with a patient I remember most clearly. I had been this patient's nurse for a few days in a row, and I remember thinking I was being very patient focused in my communication style. So I introduced myself with every encounter. I made sure I explained all of my procedures to him. And when he was finally extubated a few days later, meaning that that breathing tube or the advanced airway came out of his mouth and he could speak again, he told me he was really mad at me. He used the word livid. And I have to say, I felt very confused because I really thought I was doing everything right. So I remember I pulled up a chair, I apologized, and I asked him if he could tell me what I had done to make him feel so mad. And he was actually quite obliging in explaining the situation to me. He said, "It's the way that you were talking to me, at me." He said, "You didn't give me a chance to answer any of your questions or even to ask me myself." And I've reflected so much about that conversation over the years. It changed my clinical practice, and it obviously planted some very big questions about how we support patient communication in the ICU. So in the ICU, patient-clinician communication most often occurs through the interpretation of body movements, so gestures, head nods, sometimes making noise against the side of the bed, and lip reading. And if anyone here has had experiences trying to lip read, or even watched the YouTube clips called bad lip reading, you know how wrong it can go, okay? And like the story I shared, these means of interactions are often deemed to be inadequate, time-consuming, and entirely ineffective. And patients have described the experience of communication difficulty as frustrating and dehumanizing. Communication difficulty places patients at risk for preventable adverse events. This includes the under-recognition and under-treatment of pain, anxiety, shortness of breath, just as some examples. And in the long term, it could lead to chronic pain, depression, and PTSD or post-traumatic stress disorder. It also impedes patient participation in daily decision-making, so day-to-day decisions in their care, as well as overall goals of care conversations, and simply just communicating with loved ones. And so the problem of patient communication difficulty in the ICU also affects ICU clinicians. So a recent survey in the Netherlands actually confirmed that patient communication difficulty in the ICU reduces clinician job satisfaction. So it affects everybody. So many types of communication aids have been developed to assist people who have communication disabilities or have difficulty expressing their needs using their voice. And these communication aids include augmentative and alternative communication strategies, or AAC. I'll use the term AAC for short. AACs include aids that don't restore speech, such as those pointing boards, communication pointing boards, alphabet boards, emotion boards, things that people can point to, writing boards, clipboards, pencils, pens, as well as some communication apps. There are also AAC that restore speech. And so an example of that would be like the electrolarynx over in the bottom left-hand corner there. Now, communication aids can also include a group of tools that restore voice. So that's the person's own voice. And a good example of that would be something like the one-way speaking valve. So that's we use a Passy-Muir valve here in the hospital. And we know through recently published systematic reviews that these communication aids are actually quite effective at improving patient communication and their quality of life. So patient communication difficulty in the ICU is a clinical problem that has been investigated for at least the past 40 years. Pat Ashworth conducted an important study in 1980 in the UK titled Care to Communicate. And she was looking at ICU nurse communication with patients. And her conclusions included that ICU nurses care about communicating with patients, but that communication is inconsistent and unstandardized in the ICU. And sadly, globally, not much has really changed since then. So even in ICUs that have access to these communication aids, their use is not consistent. And this potentially leaves millions of patients a year globally at risk for voicelessness and not only frustration, but also some of those preventable adverse hospital events. Okay, so this global and historical poor integration of these tools into practice, we call an example of an evidence to practice gap, signal to us that there were likely some unresolved barriers to their use in the ICU. So something was going on, there was something getting in the way, and we haven't put our finger on it quite yet. This prompted the design and completion of a scoping review answering the question, what are barriers to and facilitators for using communication strategies with adults who have an advanced airway in the ICU? And because we were interested in that evidence to practice gap, we use the theoretical domains framework, which is a behavior change framework in our analysis. We coded 39 unique barriers and 46 unique facilitators or enablers from 44 included studies to these 14 domains of the TDF. Okay, so quite a number of facilitators and barriers, and we coded them to these constructs of this behavior change framework. Lack of skills and a lack of availability of tools, as well as negative emotions, were actually among the most frequently reported barriers. You can see that on the left there. And then reinforcement, so things that actually worked, tools that produce speech or positive emotions, family presence and other contextual factors, and beliefs about social and professional roles were among the most frequently reported facilitators. You can see that on the right there. Pardon me. We also identified several gaps in the ICU communication evidence base, and these included a lack of Canadian studies, and very few, surprisingly, actually very few studies that included the perspectives of family members and interprofessional team members. Most of the results came from nurses and patients. And so the number and range of barriers and facilitators that we identified underscored the need for a bundled or multi-faceted approach to address this problem. And also it underscored the complexity of this problem. And just as we were publishing this scoping review in January of 2020, the COVID-19 pandemic was announced. And with the pandemic came some very important contextual changes in the ICU. We needed to understand this new context before we proceeded to address the evidence to practice gap in the ICU. So as you all know, each wave in the COVID-19 pandemic had its own unique features and contextual challenges. And the bulk of the research I'm going to talk about took place during the first 4 waves of the pandemic. And some contextual features to remember, if you can, were shortages of masks and ventilators, uncertainty about the infectivity of the virus, and actually the emergence of the vaccines over that time. And in Canada, at this time, approximately 16 to 25% of people who were hospitalized with confirmed COVID-19 required ICU level care. And of those requiring ICU, 25% died there. So not only did this represent this increased demand for ICU beds, equipment, and skilled staff, it also represented an unprecedented accumulation of stress, fear, and grief. So COVID-19 changed, one participant called the emotional ambiance in the ICU. And it also introduced sort of widespread infection prevention and control conditions. So these IPAC conditions included the use of personal protective equipment, such as masks, visors, gowns, goggles. It also introduced patient isolation, minimizing entry into rooms, and pretty strict visitor restrictions. And these contextual changes actually heightened the complexity of patient communication difficulty and support in the ICU. So it took a problem that was pretty complex to begin with and made it even more complicated. A quick note about complex interventions. The Medical Research Council, or MRC framework for complex intervention design, is probably the most frequently used framework for designing and evaluating complex interventions. And their guidance includes using a stepwise approach to understand end user needs before large-scale evaluation. And this is meant to reduce research waste, including the risk of testing an intervention in a large, expensive trial that doesn't meet the needs of end users. And for us, this meant we were going to take a multi-phase approach to addressing this problem. MRC guidance also suggests a shift towards greater stakeholder involvement. So we incorporated co-design methods in our design. And finally, it recommends the use of acceptability theory, and this ensures that whatever intervention we're talking about is acceptable and appropriate for the needs of the end users. So accordingly, we use the theoretical framework of acceptability, or the TFA, which defines acceptability as a multifaceted construct that reflects the extent to which people delivering or receiving an intervention in healthcare consider it appropriate based on their cognitive, or the way they think about it, or emotional responses to the intervention. And you can see there are 7 constructs to this framework, and these include effective attitude, burden, ethicality, intervention coherence, opportunity costs, self-efficacy, and perceived effectiveness. So this framework allowed us to look at acceptability of an intervention beyond simply satisfaction. So you can see there we designed a 3-phase study to understand, design or co-design, and then evaluate the acceptability of a patient communication intervention you could use in the ICU, both during and beyond the COVID-19 pandemic. And though each phase was a distinct study, the results from one led directly to the next. And in the following slides, I'll just briefly describe each of these 3 phases. Okay, phase 1, information gathering. So this was conducted between January and April of 2021. And we published the results in the Journal of Advanced Nursing. And in this study, we used a qualitative design to answer the question, what are barriers to and facilitators for supporting patient communication in the adult ICU during the COVID-19 pandemic? We wanted to know what the barriers, facilitators were in conditions in the ICU during this pandemic. So we conducted 29 interviews with patients, family members, and professionally diverse ICU healthcare providers from a single medical surgical ICU and a community teaching hospital in Toronto. And we used those 7 constructs of the TFA to analyze our results. I'll just briefly describe the results here. Overall, participants reported that they highly valued supporting patient communication in the ICU, and actually even more so during pandemic conditions. Reported barriers included a highly stressful environment, the loss of family due to visitor restrictions, the discomfort of PPE, and the loss of verbal and nonverbal message transmission with PPE. One participant said it was like a wall went up. It was actually quite a powerful interview. And another barrier was an overall lack of tools and training for communication support. So tools were around, but they were not consistently used and they were hard to find. Healthcare providers also reported a constant balancing of time and safety priorities. Facilitators were also described. So healthcare providers were adamant that any new intervention, anything that we do to address this, should build on current practices. And they discouraged actively us reinventing the wheel in any way. They also included really thinking about leadership support. And so this is through the provision of communication tools, through the provision of adequate PPE, and through regular and transparent communication with the team, particularly during all this uncertainty. So phase 2 in our 3-phase approach was the intervention co-design phase. And this took place sort of over the summer, May to September 2021. Now, co-design is defined as the act of intentionally creating a solution with the people who will experience it. So doing research with rather than on. And in this co-design phase, we aimed to create a tailored communication intervention and implementation plan addressing those previously reported barriers and facilitators. We wanted to address the actual problems. And although I enjoyed all phases of this study, this was actually my favorite. It's really an exciting part of the study overall. So we assembled a co-design committee, and that included patients, families, and diverse ICU healthcare providers. We actually had a member of the hospital IPAC team to ensure that the intervention met up-to-date IPAC standards. And we held 5 meetings using Zoom, during which we iteratively created and designed both an intervention and an implementation plan or rollout plan. Excuse me. So the intervention we designed was named COPE. And this stands for co-designed bundled patient communication intervention for the use in the ICU during and beyond the COVID-19 pandemic. And the COPE intervention has 3 main components. The first is tools. So this includes tools in a physical communication cart and one in an electronic or e-cart. It also includes training. And this is via the provision of evidence-based communication education modules. And thirdly, it contains a section called Family Connection Information. I'll explain it a little bit more in the coming slides. I'll move through these pretty quick, but I really wanted to show some main features of the COPE intervention, some actual photos of them. So the tool cart was a simple dedicated cart that was well stocked and labeled and centered at the nursing station. You can see sort of how clean it was. We had a sharpener. We had the team recommended pencils over pens because of the strength of the patients. They didn't want to have to press too hard. There are communication boards there. There were some coil books, loose leaf paper, clipboards. So each of these drawers had something different, and that was evidence-based that the co-design committee recommended. Another recommendation from the co-design committee was to include a communication, assessment, and treatment algorithm on the cart to give guidance to the team. Which tool should I pick? What's the one that's going to work the best for my patient? And they also recommended placing cleaning and disposal instructions for the tools, either right on the cart or very close by. Here's some examples of evidence-based and easy to use, very simple and scalable communication tools that were selected by the committee. And they were included both inside the cart. I'll show you kind of like we use plastic sheet protectors, but I think, we could also have laminated, sort of in a bundle in the cart, and also in printable PDF format in the e-cart. So they were in both places. The co-design committee wanted to include an e-cart since it ensured an easy access to tools. And this was meant to save clinicians the time and effort to find or create them. One participant said it gives them less reasons to say no. So remove some of the barriers. The e-cart is located on the hospital's intranet, so the internal ICU page. And what we did was we used a consistent visual symbol there. I've circled it for COPE, and it's a direct link to the communication service. This slide is horrendously busy, so don't worry too much about it, but I've just highlighted some of the sections on the communication webpage. This includes where healthcare providers can find recommended apps for their own personal devices or for the few iPads. There are translation apps, there are pointing board apps, these AACs. And as well, there's an area where they can access those printable PDFs. I think one of my favorite elements of it is that we linked to another website, patient provider forum, patient provider communication forum, and they have free pre-translated communication boards that the staff can access, as well as actually some interesting videos on how to communicate when wearing PPE. So a number of really good free resources out there that we collated with credit, obviously, onto this page. We included the free evidence-based communication modules, and these modules are from the Speaks To website from Dr. Mary Beth Happ and her team in the US. And each of these 6 modules is about 10 minutes long, and they each go over a different element of patient communication training skills. And given the high stress environment of the ICU during the pandemic, the co-design members actually favored that these modules were optional rather than mandatory for the staff. So to address this recommendation, what we did was we incorporated the contents of these modules into very short education sessions at Huddle during the implementation. So we did a topic a week. In the family connections section, we included a live link to the ever-changing visitor policy. So the co-design committee actually recommended that we include tips on how to support healthcare providers, patients, and families during virtual visits. Our patient and family members of the co-design committee were actually very vocal about this, and they encouraged us that when somebody, for example, is having a video call, that they introduce themselves, explain their role. A lot is lost when family is not physically present, and they really encouraged us to bridge that gap. So there's some tips there that they recommended. Okay, so I mentioned there was an intervention and the implementation plan. So the rollout plan or the implementation plan, what we did was we included published recommendations for implementing bundled interventions in the ICU. So evidence-based ways of implementing bundles in the ICU, as well as suggestions made by the co-design committee. So this ensured that the rollout was actually tailored to what works in that specific environment. And you can see that it was a very multimodal strategy. And some of the notable features were that we had 2 facilitators. We used huddles, emails, posters, labeled pens of swag items, bedside teaching, and we had no shortage of leadership endorsement. And this really was important in that it signaled this cultural shift of visibly prioritizing patient communication support in the ICU. Share some more photos. Here are some images that we captured during the 8-week implementation. So there's a photo of the central location of the cart in a very busy, wonderful ICU. This is an incredible speech language therapist at our facility, Soledad Sancia, and she was the co-facilitator for the project. Here she is doing an education session. Some examples of our one-to-one and small group demonstrations, both with our healthcare provider teams and also for, with nurses one-to-one at the bedside when they're trying to work through which tool to use when. And then just a single image, but really not necessarily capturing the extent to which leadership really supported us in this project. They provided many accolades to the team, and that was really important, I think, for them to hear that in this very difficult time, the efforts that the team were making to support patient communication safety were recognized. So it was an important part. We wanted everyone on the unit to know what COPE was and exactly where to find the components. So we had a raffle. Like I mentioned, pens, lanyards. We made t-shirts, and they all had the COPE logo on it. We also had many opportunities to try, use, and modify the tools to suit patient needs. There's just a few images there of us using the tools and making some adjustments to them so that they match the needs of a very, very heterogeneous population. One patient's family actually took the idea of the printed communication boards, and they created a wonderful customized binder for their family member. And it was meant to really speak to his particular communication style and needs. Okay, phase 3. So between then October 2021, and March 2022, phase 3, which was the mixed method acceptability evaluations completed, and our results were just published in Nursing and Critical Care. And I'll just say using mixed methods for this really allowed us to evaluate not only if COPE was considered acceptable, appropriate, and feasible for use in this context, but also like what features made it acceptable and which ones made it not acceptable. It allowed us to dig a little bit deeper into its acceptability beyond just was it or was it not. So for the quantitative arm of the study, so in the mixed methods, we often use quantitative and qualitative together, so one way of going about it. The quantitative arm of the study, of our eligible participants, 64 participated, so 64 participants filled the survey. For the qualitative arm, we conducted 23 interviews, and this included professionally diverse healthcare providers, patients, and family members. So to answer research question 1, which was, What proportion of ICU healthcare providers using this COPE intervention rate it to be acceptable, appropriate, and feasible for use in this context? We used some descriptive statistics, and we basically noted the proportion of participants that reported that COPE was acceptable, appropriate, feasible. And so you can see the results there, almost over 80% for all three. So overall, very positive quantitative results. It met their needs. Research question 2 was, how do patients, ICU healthcare providers, and families who are exposed to the COPE intervention describe, not rate, but describe their acceptability for use in the adult ICU during the COVID-19 pandemic? So we used a qualitative analysis using the TFA again to answer that question. Providers reported that the co-design of COPE actually increased their feelings of ownership of the intervention. They were happy that their voices were heard. They reported that COPE reduced the burdens of supporting patient communication through improved access and shared accountability across all professions. They reported that COPE promoted their professional practices, allowed them to do their job, and that finally patient communication was prioritized in a tangible way. They all wished for more practice and training with the tools. And despite its central location in the heart of the unit, as they said, they wished for it to be even closer to the bedside and further integrated in day-to-day workflow. Patients and families quite emphatically reported relief that the tools were available. And this was so that their loved ones could report their symptoms and support their autonomy. And features that may have reduced the burdens of COPE included the simplicity of the two tools and familiarity. So the more someone used the tool, the less burden was associated with using it. An example of that was a patient who expressed that she was very comfortable with the pointing board, the alphabet board. She loved it. When someone tried to advance that in a way so that we're using a more elaborative way of communicating, she said that just takes too much energy. And she really preferred the familiarity she had with the alphabet board. It really worked for her. So, although that the patients really reported that the tools were working for them, some reported that they were still very frustrating to use. And these primarily were patients who had a difficult time using their hands and arms, either due to illness or due to restraint. But these patients and participants actually still said that these were a good start. So very generous. And after the respective of the quantitative and qualitative data, we merged them to answer research question 3, which was, how do those ICU healthcare provider, patient, and family qualitative descriptions of acceptability expand our understanding of the ratings? So how does one help us understand the other? And we use data integration methods like joint table analysis to compare these data sets and see where they converge. So where there was agreement, so where there were positive descriptions and high scores, and where they diverged, so where they may have disagreed, where there was room for improvement. And this allowed us to achieve a deeper understanding of the results and then also identify recommendations to improve the acceptability of this COPE intervention before we test it in a bigger study. And based on these mixed method analysis, some of the recommendations included provision of a variety of easy to use, IPAC approved communication tools in a central location as a minimum. Okay. Then supporting family presence, either in person or virtually. Family were the ones who were modifying the tools and ensuring that the tools were appropriate and really specific to their loved one. Using ongoing stakeholder consultation and actually a communication champion team, a longer implementation period and ongoing education about patient communication tools and strategies. So in other words, more practice and more intentional education about supporting patient communication. And the integration of communication tools into ICU workflow and processes of care, as well as having them closer to the bedside. So one way in which we've activated this in practice at this hospital is our speech language therapists attend our tracheostomy rounds, led by one of my physician colleagues, Dr. Marcus Cargill, and we talk about communication in these rounds on a weekly basis. And finally, ongoing leadership endorsement and acknowledgement of the emotional, physical, and skill work of supporting patient communication in the ICU, as well as the institutional support of ICU staff wellness. Okay, I'll end there, but I just wanted to thank everyone again who supported this work. Dr. Dale, my committee, my co-facilitator or the co-facilitator, Soledad, the entire co-design team, the MGH ICU staff, patients, families. Have to thank the multi-professional team that I work with at MGH and the leaders who supported my continuing education and my wellness through all of this, and as well as the REB who worked with me to ensure that I designed a safe and feasible project. Thank you, thank you, thank you to the TD Community Health Research Grant at MGH, the Canadian Nurses Foundation, the amazing donors at Lawrence S. Bloomberg Faculty of Nursing for funding this work and supporting them. Together, all of us, we all created a usable and tailored communication intervention that's ready to go in our ICU, as well as other applicable care environments. We have the basis for a Canadian program of research for understanding and supporting patient communication and safety in the ICU. And we have the beginnings of a multi-professional communication champion team who not only care, obviously, to communicate with patients, but who are shifting the culture of patient and clinician safety by addressing the capacity to support this essential and skilled practice in the ICU. So thank you all again for welcoming me and being here with me today. I'm very happy to answer any questions that I can.
Thank you so much for that great presentation, Laura. If anyone has any questions, please feel free to raise your hand or put them into the chat box. Hi, Mickey.
Hi, Laura, I just want to thank you for the presentation. Thank you for the excellent work. I had the privilege of witnessing the team's excitement when Laura was introducing this to the team. And even though it was during, the waves of COVID and it was such a difficult time, the team excitement was palpable. And your story about your communication with your patient that you gave back at the very beginning, I remember that way back when in my ICU days. And I remember a patient, once that patient was extubated, she yelled at me right away, and couldn't I understand that she didn't like to have her feet covered. And I never forgot that I totally was caring for that patient the way that I thought that she needed to be cared for, not the way that she wanted and needed to be cared for. And so I just think this is fabulous, tremendous work.
Thank you. I loved having you there in the ICU. I too was, and I hate to admit this, but I was surprised pleasantly at how the project was embraced. I was nervous. I thought, oh my gosh, I'm coming in there. I worked in the ICU. I know how hard it is to support patient communication, how much time it takes. And I'm going to be asking people to do something that maybe they don't want to do. And that feels kind of weird as somebody, but people wanted it. They actually said to me that they actually wished that the education modules were mandatory. I heard after the fact. And I thought, wow, this really challenged my my own assumptions. So thank you, Mickey.
And I just see Craig has his hand up as well.
Oh, great work, Laura. Great presentation, and just a massive project during COVID-19 as well, which and remarkably funded too. So great, congratulations. I just wanted to ask you to describe a bit more the integration with the tracheostomy team, because I think this sounds really innovative and could have legs across multiple organizations where we see voiceless patients in many locations in the hospital. Can you tell us a bit more about that?
Oh yeah, happy to. Dr. Cargill is here as well, in case I missed something, but I will say that the integration of communication assessment and treatment using advanced technologies, so using AAC that might require, even an application for a specialized tool, really took off around the time that Soledad and I were facilitating the implementation. And the speech language therapists were already part of the tracheostomy team. They're a very keen bunch, and Dr. Cargill welcomed them and actually makes space to talk about communication issues with patients, all the patients in the hospital who have an advanced airway. And I think that kind of physician championing and, really expert SLPs are a beautiful combination. I had very little to do with it except to say this is fantastic because it brought the profile of communication difficulty and addressing communication difficulty using a multi-professional approach into the limelight. Marcus, am I missing any key elements there?
No, I think that's well said, Laura, and thanks for the presentation. For all of you who don't know me, I'm a division head of respirology, and I started and launched our trach team along with Laura's help, our speech pathologist help, and all of the RTs help. Happy RT week, by the way, if any RTs are on. It's truly necessary, and this is a very overlooked part of the care of the patient. Communication is terribly frustrating, of course, as you all know, if you have somebody who's either has a tracheostomy tube or who's intubated, and super challenging. It's a very, very important part of the complete care of the patient. The tracheostomy team, and Laura did a lot. She's quick to describe the efforts of speech pathologists and so forth, and Soledad. They're all contributing, wonderfully to very patient-centered care and to improving the quality of life of these patients. My take on it is that it's not a single one and done. It's individualized per patient. I think Laura showed multiple different communication strategies. Lots of them take effort, not so much from the physician per se, but other than supporting and being a champion of it, but from Laura, the nurse practitioners, the speech pathologists, in order to engage the patient and the families, teach them how to use the various tools. And then there have been little barriers in terms of bringing the tools in. Some of them have some costs associated with them. Some need some funding, of course. How to deliver an iPad, for example, to a patient's bedside, or just even the communication board. All of that takes ongoing work and effort. So I think what we've learned together, and wasn't my vision at the beginning so much, because I learned from everybody and the expertise of the multidisciplinary team, is that the trach team has allowed us to have open discussion about these opportunities. Figure out how to get over the barriers, how to bring in the equipment, how to change the policies and procedures of the institution to facilitate this aspect of the care. And once those things are taken care of, then the goodness from the speech pathologist and Laura, their kind and empathic care that they provide comes out, and they're able to implement those tools. And so that's been really a real benefit from the tracheostomy team, I think, not just managing the airway and a piece of plastic that's in their neck and deciding to change it. So I'm hopeful that our progress here, will continue and will grow. We'll become old hat for the day-to-day care of the patients, and everybody will be just expecting this. And then that can be shared with our colleagues at other institutions that also have tracheostomy care teams. Maybe don't run them quite the same, but have these teams and can further improve the care of the patients across the province. I think we at Michael Garron have a very, very integral role because of our hub and spoke model for our weaning center and our long-term ventilation patients and the new long-term stay ICU patients that are coming, because we always have about 30 patients that have tracheostomies in the institution that have communication issues. So I'm hopeful that and excited that this work will continue and grow under the good direction of Laura and Soledad and our other speech pathologists. So thanks so much for all your hard work and making the lives of patients better.
Thank you for your support.
I see, Laura, another question in the chat. So it says, it's from Kimberly Widger. She says, wonderful and impactful work, Laura. What is your plan for expanding this intervention across Canada? Having recently had a family member intubated in an ICU, I can say help is needed to facilitate communication in other ICUs across the country.
Yeah, absolutely. I'm sorry that you're having that experience. It's not an easy place to be on either side. And, this issue of patient communication difficulty, as you saw kind of in some of the slides, is a global issue. There's evidence coming in from all over the world and for decades now that it's not well supported. In terms of next sort of steps in spreading through Canada and Ontario, obviously maybe I'll take this in two ways. The first one is really sharing the prioritization, the importance to prioritize this kind of work, and that is supporting patient communication through multi-professional teams and trade care teams and things like that. And the other way I'll maybe talk about this is just some of the next steps that I'm going to take sort of with the COPE work. So the first, in terms of sharing why it's important to prioritize patient communication in this patient population, either patients who are just waking from sedation or tracheostomized. So this is like a long stay ICU patient. Dr. Cargill sort of alluded to it, that our hospital actually plays a really great role in the province as part of what they call as a hub and spoke model. So we're one of the expert hubs, and we have a number of partners, our ICU partners. And what we're trying to do is share some of the recent research that we've been involved in. Been involved in a series of studies that help to identify patient, family, and clinician prioritize actual processes of care. That's a mouthful, but what is important to patients and families and healthcare providers who are in ICU and who are there for a little bit longer than 3 to 4 days. And one of those priorities of care that's been identified, one of the 11, is supporting patient communication. And so it's there, it's stamped in one of the 11 priorities. And so we're trying to spread this checklist, as a potentially checklist of these actionable processes of care to our partner ICUs and supporting that. And what we can do is we can provide some examples of how they can engage their SLP colleagues. We can certainly share our research findings. The beauty, I think, of the COPE and why it worked out well in our site was because from the beginning, we engaged the team, right? So this is an intervention that really resonates with this ICU as a community teaching hospital ICU during pandemic conditions. And they felt ownership of it. So what someone could do is take the COPE intervention, which is ready to go and published and described, and tailor it a little further to their environment and use it there. So answer one is we're trying to share the importance of prioritizing patient communication for this population. The second answer is I'm hoping that once I've defended my thesis that I can move on to the next steps, and that is designing a larger scale, possibly multi-site trial, looking at how COPE can improve potentially patient-reported outcomes, such as reporting pain, anxiety, dyspnea, shortness of breath, ease of communication, and working with a team. Well, I'm actually very honored to be a member of a very large international team with Dr. Dale and some of the authors of the work I presented there on identifying core outcomes. So we're really hoping to advance the communication evidence base so that we can start to see some improvements. Dr. Widger, I hope that somewhat answered your, it's a bit of a long-winded answer. I hope that helped. It's going to be my program of research, so I'm going to do my best.
Thank you, Laura. And I see Soledad has their hand up.
Yes, hi. Thank you so much, Laura, for this talk. As a speech pathologist, seeing somebody else take on communication the way you did is amazing, because we've only been telling everybody and their dogs that communication is everybody's business.
Everybody's business.
Yeah, and so for you to put it at the front line like this is great. The other thing that I just wanted to add to other people, because we've had you and I have had many conversations about this. We always talked about the idea of like a communication vulnerability scale, something like that. People could, the same way there's like false risk and all, skin integrity and like all these little checks that nurses and the team has to do to make sure, to manage risk for a patient. We often talked about having a scale like this to identify people at risk of not being able to communicate. So now it doesn't just becomes something we do for one type of patient, but for every patient, people have to be aware that if they don't have great communication or a way to communicate, it could really impact their overall care, just like falls risk, just like oral care, just like skin integrity. So we've always talked about that in the background, you and I, but I just wanted to put it out there that your research really shed a light on how communication can have a real impact on risk going forward. So I just wanted to mention that.
Thank you, Soledad. I can see your amazing team behind you. Thank you, all of you guys back there. Yes, that was one of the most, I think, exciting moments when we had that conversation. We really started to orient the work around safety, in practice, and what that meant in terms of integrating it into common to nurses and common to team members' practices. What's familiar to them, right? If this is a safety issue, how do we align our practices for them to see it as a safety issue, and then give them a tool, right, to engage the right response? And so, yes, stay tuned. We're definitely doing something about either characterizing the severity, or some work on resulting actions that come from it. I have a lot of exciting ideas for follow-up studies that I will most certainly engage you and Amy, who's behind you. Thank you for that comment.
Thank you. So we still have a few minutes. If anyone has any other questions, you can raise your hand or put it in the chat.
I don't know if anyone's typing, but I just want to make a last comment about the importance of supporting the teams. And I think that one of the things that kind of came out of this work and other people's work was that the overall wellness of the teams really impacts their emotional, cognitive, and physical ability to engage with patients. We don't ever want to say that, but it's the truth. And it's really quite rational if you think about it, right? And our participants were describing that. They were being very blunt, to say, if I have nothing left in here, how am I going to go and lean in there? And so I think that I don't want that to be, I think that needs to be loud and clear, that we really need to support the staff during pandemic conditions and even in normal ICU or prolonged critical care conditions. Just wanted to bring that up sort of as a key factor and recommendation that's come out of this work as well.
Laura, we have another question in the chat from Craig Dale. If you had to choose 3 ways of implementation in the ICU, which are the most important or effective? Okay, in my opinion, prior to studying for my final defense, I'm going to say definitely I loved the co-facilitation. I thought that when I co-facilitating with an internal member of the team, so in this case, the speech language therapist, was really nice because I'm not a speech expert. I am a nurse. I used to be an ICU nurse. I'm a nurse who works with vented patients now, but I'm not a speech expert, and I haven't studied that. And so 2 of us together made, I think, a killer team down there to connect with the team members. One multi-professional team member said to me, I didn't even think of this. He said, wow. He said, this is one of the few times I've ever seen something an interdisciplinary, interprofessional intervention facilitated by an interprofessional team. He really saw that. He thought this is how it should be. We shouldn't be so siloed. So I think the idea of co-facilitation with somebody who's stationed in the ICU is really important. In this case, having the SLP was really important because there's a lot of oral ambiguity with this SLP role. They've told me many times that although speech language therapy is in their title, that often they're thought of only for swallow. So number 1, co-facilitation. Number 2, I love the idea of anything other than posters. I thought the awareness building was a slight pivot
during this only 8-week implementation, because we thought, it's going to take years for people to really get used to tools, and awareness is what we really need. We need everyone to know where to run and get the clipboard, so that the poor RT in the room who was describing her experiences to me, fully gowned and gloved and masked and visored, who needs a clipboard because she wants to take a phone number from somebody, doesn't have to yell out, "Where is a clipboard?" Right? So this idea of awareness through, the labeled pens, which I use every day, the lanyard, even distributing t-shirts, ensuring that there's funding available for those elements is actually really important for the success of an implementation or rollout. And I think the third is just basically including the team in as much as possible. I actually tried to let them know at every turn what decision points in the intervention design and implementation came from them. Because very early on in the study, some people said to me, sometimes things are implemented and we're not included. And that's normal everywhere. Unfortunately, things have to move fast, but want to feel involved, right? They want to be included. They may not have very much more to add to it, but they want to feel like they have a voice in the way things are presented to them and are available to them. So I'll probably give some thought to that question, Craig, later, and think I could have answered it differently, but I'll start there. Thank you for the question.
Laura, there's another question from Lori Eve Spain. She says, is it possible to have mini packs brought into the room for each patient that can be cleaned and sanitized regularly and after the patient is discharged? Then no one is looking for items.
Yeah.
Just assume that they may need them.
Yeah, actually, so again, Soledad really helped me with this part. When we were thinking of laminating or covering the individual communication boards, I showed you guys kind of what they looked like. I thought, let's just keep them all separate. Let's get a filing thing and people can take what they want out of that centralized cart and bring it in. And she wisely said, no, Laura, no, bring in the pack, because you're going to move through these various tools. And you don't want people to leave and come and leave and come. This is, you want one pack. And so either in a situation where you can easily recycle, dispose, appropriately wipe down, or like I mentioned before, like just a single use dispose. It could also travel with them if they're not in their own isolation conditions. We've left them with people to keep. So it's a very good point, very good question. That was something that we considered and came to as we were designing the intervention.
Great. Well, thank you so much, Laura. We're just out of time now, but I'm sure if anyone has any other questions, maybe they could reach out to you directly. We really appreciate you taking the time today to do this talk for our alumni community and the Bloomberg nursing community, and for sharing your doctoral research with us. So in closing, I'd like to thank everyone for joining us today, and I hope that everyone enjoys the rest of their day. Thank you.
Thank you, everyone.